Welcome to another CME podcast episode from NEI, the Neuroscience Education Institute. In today's CME episode, Dr. Andrew Cutler will be interviewing Dr. Deanna Perkins about best practices for shared decision-making and patient education for optimal treatment of tardive dyskinesia. For complete CME information, please refer to this podcast description page or go to nei.global/podcast. Let's listen in as Drs. Cutler and Perkins discuss the current research and guidelines on patient education and shared decision-making for treating tardive dyskinesia.
Hello and welcome to another NEI podcast. I'm Dr. Andy Cutler, Chief Medical Officer of NEI, and this is episode 2 of a 3-part series having to do with tardive dyskinesia. And the title of today's episode is Shared Decision-Making and Patient Education for Optimizing Treatment of Tardive Dyskinesia. And it's a real pleasure and honor today to have as my guest Dr. Deanna Perkins, who's at the University of North Carolina and whose work I've certainly admired for many years. So it's wonderful to have you here, Deanna. Welcome.
Thank you so much for inviting me, Andy. It's my pleasure to participate. This is going to be fun.
I think so, too. Well, let's start setting the stage here and talk about the importance of diagnosing tardive dyskinesia. How would you recommend that clinicians think about recognizing and diagnosing tardive dyskinesia?
I think in terms of the diagnosis, we need to do a physical exam. And I actually find that I'm aware of patients' movements, I think the whole time that I'm involved in managing them, because sometimes the earliest symptoms of tardive dyskinesia I'll see them just during a regular interview, a regular evaluation. If the patient's getting a little anxious, I might start to see some mouth movements or tongue movement. And so I think it's important that we're aware of the potential for tardive dyskinesia the entire time that we're treating patients. And that is in addition to, of course, the formal evaluation, the AIMS.
Yeah, I agree. What role can family members and caregivers play in making that diagnosis?
Well, family members and patients just need to be aware of the risk of emerging dyskinetic movements and what that actually means. So it's part of the discussion about medication side effects, and that's especially important for off-label use. So use for non-psychotic indications, and I know clinicians will recommend them. They do find them valuable, but especially in elderly patients, to make sure that both family members and the patient themselves have awareness about the risk of dyskinetic movements and know what that is, know what they look like, know what to look for.
How do you describe them to family members? How do you describe these movements?
So I usually start by describing them while I'm doing an AIMS. So I'm explaining to the patient, and it's great if there's a family member that can be present as well. So I'll explain what we'll be looking for and the importance of kind of having a baseline, because everyone can have little twitches or little tics now and then. So we just need to get some sense of where the person is now. And I'll introduce that I'm going to be looking at the different parts of the body that tardive dyskinesia can affect. And when I'll start with oral facial, and before I ask them to do the movement, I'll explain to them why and what I'm looking for. And sometimes I imitate them as well. So I'll give an example of what a dyskinetic movement might look like. And in terms of lip pursing or other oral facial dyskinesias, or a dyskinetic or chorioathetoid movement in a hand or an arm. So taking the time to do that evaluation and explaining it, I think, is a key time for educating patients. It's relevant and they know why you're doing this. You're asking them to stick out their tongue. You might be asking them to take off their shoes and look at their toe movements. Like, that just seems like a weird thing for a doctor to ask. So if you're explaining why and that this is something that you take seriously, then I think the patients will as well.
I certainly agree. And I have to be honest, Deanna, I also demonstrate these movements myself. Sometimes you feel a little silly, but I think it's really helpful for them to see what you're talking about.
Yeah.
You know, I was asked a question the other day that I want to get your take on, and that is, how do I explain the risk of tardive dyskinesia without scaring off the patient or family member?
This is the same problem we have with many of the serious medication side effects, that whether it's metabolic syndrome or just even just the weight gain. We don't want our patients to experience these medication side effects, but that doesn't mean that we shouldn't talk about them with the patient. And so I think we need to be comfortable that knowing that these medications have risk of these potentially serious side effects, that there's the likelihood is that the benefits are going to far outweigh the risk. And so talking about the medication side effects is done in the context of this shared decision making. Okay, what are the symptoms of the illness that the person's experiencing? How might this medication help? What would that mean for the person to have these symptoms improved? And then what are the potential downside? And so when I'm discussing dyskinetic movements in particular, I talk about the importance of early identification, early recognition, because we can then move towards earlier interventions that reduce the risk of developing full-blown dyskinetic movement disorder, full-blown tardive dyskinesia. So I think I'm comfortable with it. And if I'm comfortable with that discussion and understanding the person's perspective, I think the patients are going to be comfortable as well. So that's the first place for us to be comfortable.
I strongly agree with you. And it's interesting, episode 1 in this 3-part series was the importance of early diagnosis. And I couldn't agree with you more that there is some evidence that the sooner you detect the TD and the sooner you intervene, possibly the better the outcome is, the more likely it is, for instance, to reverse or to resolve. We know a lot of these older studies were done with patients who'd had TD for years, and it could be that by then it's too late.
Yep. Yes, absolutely. And so I think that patients are often, it's reassuring to know that tardive dyskinesia, you don't wake up with it overnight. It emerges typically relatively slowly, and that so we can recognize it at its earliest stages, and then we can do something about it, which is the other thing that's reassuring to patients, is that there are ways of addressing that adverse event, that side effect of the antipsychotic medications and other dopamine blocking drugs.
Yes, I really agree. And part 3 of our series here will be on treatment and intervention. So we're focusing today really on the family members and shared decision making and this kind of thing. Deanna, one of the things about TD that's I've always found curious is that there's not really a sensory component to it. So the patient themselves may be unaware. So it seems to me it's very important to involve a family member or caregiver in the process.
Absolutely. That's one of the things as I'm educating patients and hopefully caregivers, family members as well, about what to look for. It is that the person themselves may be unaware. And the first time that they may actually notice is when someone else remarks about them maybe having a tic or why are you making that face? And then to have that be a flag that, that maybe this is something that I need to talk to my doctor about. Or maybe this is something that I need to ask a family member about and to see if I'm making these unusual movements when I'm not even aware of them. So I think it's, again, framing the physical evaluation in that way is really important, that we're doing this so that you understand what it is we're looking for. And if other people are saying to you, they're noticing something, that I want you to take that seriously and tell me about it. So I think that's it. The other thing is if a family member is noticing them or even a friend is noticing it, to take a movie of it. All of us have these cameras now, almost everyone does. And it is just so helpful for me to actually see what the movement looks like. So can they take a movie if they notice you doing these movements kind of thing?
Oh, I really agree. I do that too all the time. I have patients or family bring me videos of things.
Yeah.
And sometimes it may be a movement disorder other than TD. It might be Parkinsonism or something else.
Yeah.
So that's important.
Yeah. Absolutely. And so the other thing that patients might notice is the impact on their function. They may notice that they're dropping things or that they're having trouble brushing their hair or they're spilling food. And it's embarrassing that they're having these kind of functional problems. And so that is the other place that a patient themselves may be aware. And also having family members and caregivers understand that if they start to notice these kind of changes in function, that again, that's something that's important to bring up with their healthcare provider.
Yeah, I agree. And I think it's so important to get the family member or caregiver's buy-in because they're also in a position, of course, to counter or undermine the treatment plan. They may say, don't take this medicine unless they understand the risk you're talking about. The newer atypical antipsychotics, the risk may be maybe 8 to 10% of patients. It's a minority. It's not nothing. But I find when I quote that kind of statistic, that sometimes helps. And I think it's also important to get the patient's permission to allow the family member or caregiver to participate and to observe and comment. So it's really important to get buy-in from both sides, I think.
Yeah, I agree. And I think that it's that the more these can be treated as in a matter-of-fact kind of way, acknowledging that it can be embarrassing, that even though it's normal to perceive these things as embarrassing, that it's important that the person not feel like they can't bring it up with me, that this is something we've already talked about, that we hope that this doesn't happen. And I'm going to do everything that I can to prevent any side effect emerging. And if they do emerge, I want to catch them early. And so having both the patient and the family member acknowledging that they may feel some embarrassment, that to look past that. Why is this happening? Why is my father spilling food on him when he didn't used to do that? And could there be a role of the medications in causing the difficulty in any of the activities of daily living? In my practice, I use, antipsychotics in almost all my patients, and because I treat schizophrenia primarily. But if a family member becomes aware that their, say, elderly parent may not be as aware of the medications that are being prescribed, and that a medication, these kind of unusual symptoms have emerged, to make sure that they bring it up with their healthcare providers, so that to help their healthcare and asking about, could this be? Why is my father spilling food on himself? He didn't used to do that, and he's having trouble with doing these activities that he used to do quite easily. So what is this? Could there be a movement disorder that's part of it, part of the emergence of this side effect?
I hadn't really thought about this. I really like this concept of normalizing, not minimizing the risk or minimizing what TD is, but normalizing it and putting it in the context of other kinds of side effects that can be dealt with and that need to be recognized as early as possible. So putting it in that context, I think, is really helpful. And that might be part of the answer to the person's question who asked me, how do I bring this up in a way without scaring people off?
That is
and yet not minimizing, of course.
Yeah, absolutely. And I think that maybe reflects our own, as healthcare providers, discomfort about the risk of tardive dyskinesia. We know about the lawsuits, where we know that this is potentially a serious long-term outcome, and we're afraid of it. And so I think for clinicians to recognize themselves that especially if recognized early, the emergence of dyskinetic movements can be successfully addressed, and that the longer symptoms go undetected, potentially the harder these are to address. And so early recognition is really important. But looking at ourselves and saying, okay, am I comfortable with this? And if I'm not, why? And how can I get myself to a place where I am comfortable about talking about these undesirable side effects with my patients and their families?
No, I think you're absolutely right. And to be honest, I think also a lot of us were not well trained on TD, on how to recognize it and what to do about it. And for such a long time, we didn't have any effective treatments. And so there wasn't a whole lot of motivation, I don't think, to learn about it or to recognize it.
Yeah, but times have changed, and we know a lot more about how to address it. And I think we can put it in that category of an undesirable effect. But if patients are aware and if family members are aware, it can help us diagnose it, recognize tardive dyskinesia right at the earliest stages.
Yeah, that's certainly true. And also, when we think about risks of medications, I think we also have to balance out the risk of inadequately treating the psychiatric illness. And sometimes we don't think about that.
Yeah, so it's because the way I like to approach a collaborative decision-making process is to help frame it in terms of there is the problem, and for us to develop a shared understanding of the problem, the impact the problem has on the person's life, the seriousness of it. So that's the step one. The second is, here are the intervention options. And this is the likelihood that it's going to help. And of course, we'll see. Side effects like tardive dyskinesia don't typically emerge the first week you start a person on an antipsychotic. It's Tardive after all, right? It's a late onset side effects. So we have time to really understand, is this medicine going to be helpful for this symptom. And we can, of course, be aware and be looking for the longer term side effects, but to frame this is not a short-term risk. This is not one of the short-term risks of these medications. This is a longer-term risk that if this medicine works for you, if it's effective in controlling your symptoms, that one of the longer-term consequences is going to be development of movement disorders, but that's something that we can screen for and detect early. And I, as a healthcare provider, will be watching for that side effect. So I think also framing it in terms of the likelihood of happening very early on, it's just low. It's extremely low. And so let's see if this medicine works for you at all.
That's a really good point, Deanna. And I think family members and patients are used to thinking of a side effect as something that emerges early on, nausea or headache or something like that. So it is important to educate them that this is something that can show up months or even years later, right?
And that I fully agree. It is hard actually to even connect when a side effect emerges after long-term treatment. It's often hard to even tie it back to the medication that's causing the dyskinesia. That's just not the way our brains work in terms of causality. And so the patient themselves may be,
that's right,
as the disconnect movements emerge, they just may not even be connecting it to the medication that they're taking, of course, unless they've been informed and unless, of course, the healthcare provider is also monitoring for the emergence of the dyskinetic movements.
Yeah, that's so well said. I've seen that many times where the patient and family don't realize at all that it's related to the medicine. So I think that is a very important part of setting the stage and educating about this. One of the things, too, about TD that I've certainly learned a lot better over my career is that TD is more than just a cosmetic problem. It's more than just something that looks funny or looks unusual. There are significant impacts on people's quality of life. And so how can we educate patients and caregivers about those or even inquire about those aspects of TD?
Yeah, I think those conversations I save after the dyskinetic movements have emerged because, of course, I think there's just too much information to give in that initial description of the events. But once a person has developed dyskinetic movements, I'm of course going to intervene and hopefully reduce the severity. But when we've done what we can and there's still residual symptoms, that sure, there's physical consequences that in the examples of interfering with eating, interfering with ability to walk, to perform activities of daily living. But there's also that looking funny is a big deal, right? It's stigmatizing to have a movement disorder, and helping the patient learn how to manage the stigma and the reaction that other people may have to them and to their movement disorder, and then how they feel about themselves. So there's that emotional component, sort of the self-stigma. So, and different things matter to different patients, and they matter different to different family members. And one of the first things I need to understand as a provider is what's really the problem. What is the patient's perspective on what problems they're having, and truly respect their perspective, because after all, that's the one that really matters.
I think that's really well said, too. And I think exploring the specifics of how TD affects that individual's patient's life and their families is so critical. And to not assume that we know, I always say we shouldn't make the decision for them because, as we all know, there are some patients with pretty significant tardive dyskinesia who just don't seem to be as bothered by it. And then there are some with milder forms that it's devastating for them.
Yeah. Some of it's how self-confident a person is, right? A person, some people are just extremely self-confident, and despite significant health disabilities, they do great. They feel good about themselves, which is probably the most important thing. Again, if you feel good about yourself, that can help other people accept you the way you are. And so I agree.
Yeah. I also think it might have something to do with how high functioning our patients really vary with respect to how high functioning they are. And people with, say, a mood disorder who may be higher functioning, even a milder form of TD, of course, is going to have more impact on them occupationally and socially, potentially. But I don't think we should assume that people who are lower functioning couldn't be bothered by this.
Oh, of course not. And there's in people who are working, going to school, or engaged in have friends, go out, the milder forms of the twitching or the tic or however they describe it, they can having an explanation, having them have a way of explaining it to people that they're close to, that the patient feels comfortable with, and it's not, they don't have to, of course, talk about their whole health history to friends or work people at work. So coming up with what is it that you feel comfortable sharing? And if these symptoms are bothersome to you or people are remarking about them, how can you handle that? And I think it's true for just whether you're high functioning or low functioning. I think the severity of illness, these things matter to people. How you're accepted by friends and family and by the community at large matter to everybody. And so, again, respecting that person's, the individual patient's perspective, and maybe even asking about it. And that's what you mean. How does this affect you? How does this affect how you're talking to other people or doing things with other people? And if so, how does it affect it? So just being very curious and not assuming. Mostly when I assume I'm wrong, I am not.
Yeah, that's true.
So.
Yeah. I've always said that to be a good clinician is to be curious and to individualize. And I think that's exactly what you're talking about.
Yeah, absolutely.
Yeah. The other thing I really like what you're saying, and I hadn't considered this, about developing strategies and being proactive and thinking about how to handle this. And certainly, what are some of the things that we can help family members with in how to support the patient or how to deal with things that might be embarrassing or might be happening? How can we help the family?
So I think the family can, first of all, I think it's important that the patient sort of be responsible for, or that the patient needs to ask for what they need. And so that both the family members as well as myself as a healthcare provider need to listen to the patient and encourage the patient to talk about what they need help with. Because I hate it when someone rushes in and tries to help me with something that I feel perfectly competent to do myself. And I think patients feel the same way. It can be very well intentioned, but we need to look to the patients to find out what they need, what's bothering them. And so, of course, if it's a task that they're having trouble doing, there are adaptive tools. A physical therapist can help identify those sorts of things. If the tardive dyskinesia is severe enough that's affecting how a person's ability to walk, then they definitely need support, whether they need a walker or what that person needs in order to still be able to do the activities that they'd like to do. The other piece, though, is for the family members in particular to be aware of the impact of stress on symptom severity. I see this
good point.
In my own evaluations that as soon as we start moving to a stressful topic, the dyskinetic symptoms emerge, worsen, are more severe. And so for family members to be aware of that and for patients to be aware of it, and that the stress is always a problem with individuals who have a serious mental illness. Stress often impacts it in a negative way, but the dyskinetic movements is just one more thing. And so a healthy lifestyle, sleep, adequate sleep, just those regular things can be, I think, so important in maintaining a person's health, but also reducing the severity of the symptoms day to day.
That's such a good point. And I think many of the clinicians listening to us may not fully realize that the symptoms of TD can be variable over the course of the day and can be related to stress. And this is something probably also to educate family and caregivers about, that don't be surprised if the movements get worse in periods of stress. And maybe that's a way to be supportive and helpful, is to help, minimize stress as much as you can.
Yeah. And also interventions that address stress resiliency are just so key for recovery, period. But they're especially important here with dyskinetic movements. It's just striking sometimes. Like, I will have a family member tell me about these weird, movements or tics that this person is having. And then I'll come in my office and there'll be nothing. I won't see anything. And I'm like, oh, so that's where I need to be really aware that, yes, just because I'm not seen in my office doesn't mean that it isn't happening, and it doesn't mean that it isn't tardive dyskinesia. It certainly could be, because I have patients often will only experience it during times of stress, but it's still, and in fact, that's the earliest emerging symptom, is this development of these tardive dyskinetic movements when the person's a little bit stressed out.
And that gets back to your earlier point, the importance of maybe taking a video, a cell phone, when it's happening, so you can see it. And that's also important for us clinicians to think about when we're doing our AIMS exam, the importance of activating maneuvers that could bring out a movement that's not there initially.
Yeah, fair enough. And that's also a time to reinforce that the reason why we're doing this is because that it's a little bit of a stress, right? We're always working to control. It's natural to work to control your movements. And so I'm going to be distracting you, having you focus on another task. And then what I'm looking for is the rest of your body, not the hand that's doing the distraction task. And it doesn't hurt to tell people about it. It still works as a distraction task, and it helps them understand why you're doing it, and reinforces this idea that, you might just notice these emerging when you're under a time of stress. They don't happen all the time at the same level. They do get wax and wane. That's normal for tardive dyskinesia.
Yeah, and you mentioned something very important, the sense of control of our body and our movements. I think one of the bigger fears that human beings face is to be out of control, to not be in control of our body and our movements. And maybe that's something else we can educate families about to help the person to feel a little more in control, or to not, as you had mentioned earlier, not to assume the patient can't do something, to jump in to help all the time. Maybe to try to understand better what they can do and what they can't do.
Yeah, because that does undermine.
This notion of control is something I've been struck with.
I think you're right. I hadn't thought of that actually, but absolutely, it is scary to know that your body's. We like to think our conscious brain is control of everything, and of course, we know that's not true, and we take our movements for granted. But
yes.
Yeah, I can really imagine that as something that would be scary for me personally. And so that's one of the things for us to be aware of when we're talking about with our patients is if they talk about that or they reference the ability, that's the thing that's really bothering them. And of course, then, yes, it's true and acknowledging it, but what things can you steer? What are you still in control of? And then what can we do to help you get back as much control as possible? So there's the two sides of it.
Yeah, I absolutely agree with you. You mentioned something earlier I want to just get back to for a second, and that's the idea of stigma. And I've had patients tell me, or I've thought about that, having a mental illness, you often by looking at someone can't tell they have a mental illness. But if they have tardive dyskinesia, now there's something wrong and there's something weird about this person. So it is doubly stigmatizing, isn't it? To have this on top of a mental illness.
It is. And I think it's disrespectful to not acknowledge that with the patients and the families. And that may be something that, for example, would make a family member uncomfortable about going somewhere, taking their family member out with them now because of the emergence of the dyskinetic movements, and that they may be embarrassed about it. And so having that conversation about, rather than not doing things that your family member really wants to do, how can you do them in a way that you're comfortable, the patient is comfortable, your family member is comfortable, acknowledging that other people may notice, and what you'd like to do to be able to, how do you want to manage that? Because it's a truth. People will notice. And so.
Yeah, certainly true. So I want to shift gears a little bit and talk about part of the title of this podcast is shared decision making. And we hear that term, I think, thrown around, but what exactly do we mean by shared decision?
I think it means that the patient and their support system, they really do have a choice about what to do. And that it may not be the same choice that you as a healthcare provider will recommend. And I think with tardive dyskinesia, it's key, a pivotal moment is when the symptoms have emerged. Or you're seeing a patient for the first time who does have dyskinetic movements and no one's ever brought it up to them, or they're unaware of it or whatever. So I think that's the pivotal time, because then the steps, reviewing what medication the persons are taking, talking about the benefits, right? Moving into that discussion and then respecting that the decisions that patients actually make about what they would like to do. And of course, I can help structure that because you may actually want to do an intervention before you stop a medicine completely that you think, if a patient thinks the medication is help, what are the options that they have? And talking about the intervention is part of it. But really, in the end, patients are going to do what they want to do, despite what we think they should do. and that I'd rather know.
That is certainly true.
I would rather know.
Yes.
And then with that process, I treat a lot of, my clinical program is a first episode treatment program, and I work with patients who want to discontinue medication or reduce the dose of medication for all kinds of reasons. And I tell them I ask about that and I want to hear about it. And then we start to plan for what would happen if symptoms do reemerge, or make a relapse prevention plan. And I think the same thing can be done here. If a person really does want to go off of a medication, and that is, in the end, that can be a decision that's right for them. But typically it's not. Typically I'm right. And that really we should try a treatment first before going to taking those risks, and see what happens, see how it goes.
That's certainly true. I think it's hard for us as clinicians. We've had all of these years of training and experience, and we know the ins and outs of the consequences of the illness and the progression and the prognosis. I think it's hard for us to let go, again, the idea of control, to let go a little bit and to let the patient find their way here. Our model really has evolved, hasn't it, from more of a paternalistic model where the doctor knows best or the treater knows best to one where we do have to share the decision-making and acknowledge the obvious, that the patient is really in control of their own treatment and makes the ultimate decision.
But what we can do is to help them think through that process. I often take a motivational interviewing strategy when discussing medications. It's this idea about, okay, what's happened when you have stopped medicine in the past? What's happened to you? Most patients have had those experiences. And what was that like? So it's really evaluating the risk of stopping medication is typically a return of the symptoms that the medication was controlling. What would that be like for them? How would that affect their life? And so they're having to balance the impact that a relapse, which is highly likely, right, it would be against the risk of the tardive dyskinetic movements. And of course, family members are usually want to be, or caregivers are usually quite involved in those decisions because they often are involved in the outcome as the patient is. Relapse is very stressful on families and on care systems.
They suffer the
having
consequences.
patients, having those systems involved in these big decisions and letting the patient hear that perspective as well. The family member's perspective, the caregiver's perspective is an important part of the process. So it doesn't just mean a patient's first impulse is the right one. It's more, no, we do have to think through, help a person think through what they know from their past experiences to best understand the benefits as well as this new risk, this new side effects that's emerged.
That's a really good point, because the family or the caregiver suffers the consequences of these decisions, especially relapse and things like that. And I like the idea of holding up a mirror to the patient a little bit, both you and the family holding up a little bit of a mirror, because the fact is many of our patients, especially those with more severe mental illness, they don't have good insight or judgment, and they don't make good decisions. Typically.
Yeah, and I think that's true for some people with schizophrenia, where the people with the most severe schizophrenia, schizoaffective disorder, that it can be very hard for them to participate in the decision-making process because of a lack of insight and a lack of awareness of the illness. But I think there's really the majority of patients with schizophrenia do gain insight about their illness. They do understand that that there's the risk of relapse, the consequences of relapse. And I think we tend to, if we our hospitalist practice, we see the people that don't, that aren't aware or have made that decision and are having the consequences. But I think most outpatients I see really, they do have an insight. It may not be that I'm diagnosed with schizophrenia. They may have a different way of labeling the symptoms and the experiences, but it's still a perfectly valid conceptualization. So I don't think, I think that insight is not a reason to not work towards a collaborative approach. Mostly I can find common ground, and mostly patients do gain insight as their illness and their symptoms improve. And so taking that stance, and of course, when that's obviously not the case for the most severely ill patients, of course, then we use different strategies because of the reduced decision-making capacity that a person might have at that point.
Yeah, I really like what you're saying, though. Again, it comes back to individualizing. Don't assume the patient can't participate just because they have a mental illness. And don't treat every patient, let's say with schizophrenia, the same way. People have strengths and weaknesses. We all do. We're all different.
Yeah. I think one of the challenges clinicians are facing, though, is all these things that we're talking about sound good, I'm sure, but there's time. Often clinicians are working in an environment where there's a limited amount of time to have these discussions. And so I think it's important for clinicians to try and at least figure out in their healthcare system, with the limits that they have on their time, what they can do to make sure that these discussions happen. So it may not necessarily be the treatment, the medical provider that has the time to sit down and have these discussions, but that somebody on the treatment team should, or there should be having a person who's working with them, whether it's a therapist or a peer support specialist or some kind of provider, to be able to have those kind of conversations with the patient and their family. If we can't do it ourselves, I think it's at least our responsibility to try and help the patient find the resources so that those discussions can happen.
Yeah, and it is so important to have those discussions, and again, to involve the patient and the caregiver if possible in this process. I think all too often we also assume that, family is not involved or not important. And I think they're critically important in a number of ways. And now it's interesting, now that we've been doing more telemedicine, COVID, maybe one possible benefit of COVID is it taught us all how to do telemedicine. I think this often brings family and caregivers into the process in a way that they weren't before. I certainly seen the environment the patient lives in, and I've now met people that I didn't meet previously who are involved in the patient's life. What do you think about that?
Yeah, absolutely. I do. I've done telehealth pretty much exclusively. I know we are going back to in-person visits now, but I've learned I wouldn't say I'm an expert at telehealth, but I've worked to adapt. For example, I have done an AIMS, and I do AIMS via telehealth. I ask the person to move their chair so that I can see their whole body. And a family member might be there that we can call in, and I can have the family member help with making sure that the camera is placed so that I can see the patient's whole body, and having them take off their shoes and having them doing a formal AIMS. And I think I've been successful at doing one. After all, it's something that we can see. And so as long as it's video-based telehealth, we can do these evaluations. So it's no reason to not do them, to not do these evaluations because the person's involved in telehealth. I think we need to adapt because telehealth is here. More and more we'll be doing, I think, telemedicine, and not shortchanging the patient in terms of what we're doing in terms of side effect monitoring, including a formal AIMS, which I do annually on patients, and I think we all should when we're prescribing these medications.
Yeah, I'll be honest, Deanna, I do them twice a year. I know the APA guidelines, I take those as a sort of a minimum standard, but
yeah.
I don't know. I just feel more comfortable doing a little more frequently.
You're probably right. I think that makes sense. Again, I treat people so early on in the course of illness by and large. And also, I don't know how this is for you, but I'm just so aware of normal body movements. I just integrate that into what I do day to day. So anyway, but you're right. Twice a year is, I think, a better strategy.
Put it this way, in the real world, I try to schedule it twice a year. And what happens, a patient might miss their visit and before it's been 8 months. So if I schedule it for every 6 months, I end up getting at least once a year.
Yeah.
Sometimes twice a year.
Right.
That's just the real world, right?
Yeah. I was wondering, do you have strategies for how you track doing these intermittent evaluations? How do you remember when the person's... Do you have any strategies you use? I'm trying to develop some of those.
No, that's a terrific question. One of the good things about technology, and I'll be honest, I'm a little bit of a technophobe, but one of the good things about technology is it can allow us to be more systematic and to track things and to flag what needs to be done when in our visits. So there are ways you can certainly talk to your IT people or people who manage your EMR system and do that. Again, by doing it twice a year, every 6 months, it's a little easier to track that. And one of the things that I'll say in every one of my notes during the plan, I'll say patient due for AIMS, let's say in 3 months. So if I just look back at the previous note, I'll have a sense of when it needs to be done. Things like that.
Yeah, that makes sense. I use an electronic medical record and I carry forward my note. So one thing I've been doing is just putting the date there when the next one needs to be done. That's one of the things that's been helpful for me is a reminder that I'll see it I'll have the most recent, whether it's the AIMS or the hemoglobin A1C or whatever, and the date, and then a note you need to be repeated in May. So that way that helps to jog my memory, because that's a real challenge. You think you've done it recently, but patients, it all can blur. So coming up with a system to actually track when things are due can be helpful for this routine monitoring that I know all clinicians who are using these antipsychotics know that we should be doing this monitoring and on a regular basis. And I think you're right. Twice a year is probably a better, and it's such a simple evaluation to do that it's hard to argue that it shouldn't be done twice a year.
Yeah, and of course, in some EMRs, there's a section for testing. And so you can put it in there, just like you would file lab reports or something like that, so you can have the date that you last did it. And you can put the AIMS, load the AIMS into your EMR, so you'll have a date on it when you did it.
Yes.
So that's another way. But you're right, tracking is critically important.
So all of us need to come up with a way of keeping track of these things. Thanks. I like your insight, though. I hadn't done, now that you mentioned it, I do have a flag system on my EMR, and I'll look into seeing if that can be helpful. Thanks.
Sure, absolutely. Let's get back to talking about the family and the caregivers here. Let's talk about that a little bit and then get back to the shared decision making. What are some of the strategies or the effective things we can do to specifically involve the family members in this decision making process? Because it's not just about the patient. How do we get family members involved and get their buy-in, so to speak, and get their point of view on what's happening so they can be a voice in this process as well?
Yeah, when I work with, at least with my patients from the get-go, I let them know that I think family or involvement in people who matter to you is important for your recovery. So I frame it in that way, in a positive way, right? This is not, patients often will not want family involved because they don't want family to know their business. And of course, I'm going to respect the patient's confidentiality. I'm going to respect what we talk about as private unless they want to share information with others. So I frame it in a way that it's just an important part of their care. Because the first step is the family member has to be invited in, or the carer has to be invited in, or the person who's doing the supervision at the group home needs to be invited in order to participate. And so I have the patient identify who is that person or people, who is it that would be helpful, and then trying to organize their involvement. And again, this is where technology has been helpful for a long time, is the family member or the carer doesn't have to physically come to the appointment to be involved. They can come in via telemedicine. They can participate over the telephone. That doesn't mean, because often that is a barrier, right? When the patient is being scheduled, the family member may not have time. So coming up with who that is and having the patient invite them in. And usually I do it during that session that, okay, why don't we give your mom a call and ask her if she'd be willing? Because I've learned if you put it off, it won't happen.
That's a good strategy.
So doing it as part of the intervention is something else that I think is a key issue. Not, okay, your mom, let's give her a call. And then the patient is the one who's inviting mom in, and the patient, again, is the one who's setting the guardrails. What can be discussed. And the goal here is for that to help your family member help you recover, and that having them involved in that discussion and helping you let your family member know what's important to you, what's helpful and what's not helpful, right? That this is a place where we can be doing that. And so that gets them in the conversation and part of the conversation, and can help with the relationship between the carer and the patient, and also set the stage then for who should be involved in helping you make this decision. These are hard decisions. Who does your decision impact? Should we invite those people in, since your decision is going to be impacting them? You're going to need something from them, kind of thing. So that's number one, is getting them invited.
Leanna, I think that's a terrific strategy. I love how you're saying that, because that really plays into a sense of autonomy for the patient, having them have a sense of agency and control over the situation, being an active participant in their own care and what happens to them, and not just having people talk about them behind their back or making things happen to them. So that's really helpful. And also strike while the iron's hot. If you get their buy-in to talk to the family, and call from your office. I love it.
Mm-hmm. Yeah, great. So I appreciate that. I appreciate it. I just am smiling because I do have a reputation for acting in the moment because it's so effective. And the treatment team teases me about that sometimes. But yeah, that's how else to do it. Otherwise, I forget who's going to remember.
Yeah. So you mentioned that was number one. You sounded like you had a few more tips here, a few more things.
Well, the second kind of is inherent in how they're invited in is framing the role that the family member is being invited in to help the patient in the recovery process. And just as I want to understand the perspective process, to emphasize that the family member needs to understand what is helpful, what is not helpful, and how to prioritize. So that's the second is, what does that look like? What does that family member's involvement look like? And then the third is, when there is a treatment decision, identifying how the treatment decision is going to impact others, and the importance of involving now this family member in that discussion, because we've already set the stage that the family member can be helpful. They do have a perspective that matters to the patient, and they can hear the perspective. They don't necessarily have to accept it, but they can at least hear it and try and understand it. So those are so that sets the stage, because if the patient's not on board, shared family member involvement is just not going to work. And then it's the same, right? It's getting each person's perspective of what's been, say, helpful in managing tardive dyskinesia, what's not been helpful, what are other ideas, what are other resources that the family member can identify in their community. That the family member is the one that knows the community and the resources, or whatever networks that they have. How can those networks be helpful? So those are So that's I think that's the beauty of having family and carers involved, is they can often come up with ideas and strategies that I am totally not aware of. They often have really good ideas.
Yes. Yeah, that's well said. And also they can have some veto power sometimes. So if we don't bring them into the process or educate them, they can undermine the treatment decisions. I like to say they have veto power sometimes.
They absolutely can. And I think the point you made earlier about that for family members to understand the risks and be part of that discussion is so important, because after all, they are going to Google it, right? An involved family member who isn't invited in is going to be getting their information from maybe very well undermining the treatment decision that the patient's making, because they're not really aware of the real risks, and they're not able to put these in the risks and benefits in perspective. So I think that you're absolutely right. That's another reason to invite them in. They can make our job a lot easier, or they can make it a lot harder.
I agree. You mentioned people looking things up on the internet. I like to refer to Dr. Google. People will use Dr. Google sometimes. And as we know, there's a lot of legitimate information on the internet, but unfortunately, there's a lot of misinformation on the internet. And I think it's also helpful to direct people to legitimate sources of information on the internet. Don't you agree?
Absolutely. Although I myself there are, like, NAMI is a very good source. There are reputable sources, but I think I don't know, what other resources do you use? That's generally, I'll refer people to NAMI. They have they do have really nice resources, I think, that can be very helpful to patients and their families. But what other resources do you recommend?
There's actually a Tardive Dyskinesia Association, or the NOTD, if you will, and their website is www.tdhelp.org. tdhelp.org. And this is this is a great resource. It's an organization headquartered near me in Tampa, Florida, of all places.
Excellent. Wow. Because I think that one of the things about a disorder like tardive dyskinesia that can be stigmatizing and disfiguring is to talk to other people that are experiencing the same problem. There's that kind of peer support can be just so crucial. People can feel so alone. They're the only person they know with this problem. And so understanding that it affects others and how other people cope can just be so, I don't know, it can be reassuring, normalizing, and just to help a person adapt. So that's a great resource, and I wasn't aware of it.
Yeah, they're relatively newer, and it's very interesting. Their website has all kinds of resources and information, and they actually have developed something that's really fascinating based on what our earlier conversation was, a TD symptom tracker app that you can download from wherever you get your apps, and you can record the movements, you can monitor and chart them, you can monitor the effects of TD treatment. And here's something really interesting. You can record your emotions, anxiety, depression, happiness, and track lifestyle factors like sleep, exercise, and stress. Very relevant to what we were talking about earlier.
That is a
really great resource.
That is a great resource because, first of all, it often is hard for I see the patient, a snapshot of the patient. I don't see them. And we know that tardive dyskinesia is a disorder that does wax and wane in severity. So a tracker like that would just be really helpful in guiding treatment and identifying triggers, and also identifying is this intervention making a difference? I think that's an awesome idea. I love it.
Yeah, I'm very excited. They approached me only a year or two ago at a meeting, and I was really happy to find them. So, National Organization for Tardive Dyskinesia, NOTD.
Excellent.
Okay. Yeah, we're getting ready to wrap up here, but I wanted to talk about quickly. We've been talking about shared decision making, I think, in the context of the antipsychotic treatment. But I think we also need to think a little bit about shared decision making in the context of introducing a new treatment for the tardive dyskinesia, so another medicine on top of the antipsychotics, such as a VMAT2 inhibitor. How do you think we should approach that situation?
It's framed in the discussion of this side effect has emerged. Here are the options. The option could be reducing the dose of the current antipsychotic or making a switch to and I'm sure you're going to be discussing these options at another podcast, but certainly one of the options is the VMAT2 inhibitors. And so, yeah, that is one of the options, and there's the potential benefits and the risks. So I think having the patient and the family member understand and come up with a staged approach for how to address this newly diagnosed side effect. And so sometimes this is the first time you've seen the patient and they and their family member have never had this discussion. They weren't even aware that the antipsychotic was contributing or was a risk factor, and they probably weren't aware that there was actually an intervention that could be helpful. And so, again, having family members educated about tardive dyskinesia, understand it, and then help the patient make their decision about what intervention to try. But if they don't, it certainly needs to be discussed as one of the options for an intervention, and the potential benefits of the intervention as well as the side effects discussed.
I think that's really well said, Diana. The time has really flown by, and I think we've had a fairly wide-ranging discussion here. I really appreciate you taking the time to speak with me and help our audience to think a little bit more about a topic that we don't talk about a whole lot, and that's bringing the family in, education, shared decision-making. So any final words that you have for us, Diana?
I think I agree. We've had a wide-ranging conversation, and I've learned a lot. Thank you, Andy. It's been really interesting and to have this discussion and to think myself about the strategies that I use, and thinking about where I may need to do better as a clinician in terms of early recognition, tracking symptoms, and because there are interventions that are helpful, and we need to not forget about that. So I think it's, again, raising my own awareness about the importance of regular tracking for this medication side effect that can be potentially quite devastating for patients.
Yeah, I certainly agree, for patients and their families. So thank you so much. And I just want to remind our audience that this is number 2 in a 3-part series on tardive dyskinesia. And as always, I really want to thank my guest, Dr. Deanna Perkins, again, someone who is extremely prominent in the field of schizophrenia, the work you've done on First Episode Psychosis. Again, I've tracked your work for years, and we all have benefited greatly from your work. So thank you for that, and thank you for joining me today.
Thank you for inviting me. It was really my pleasure.
Great. Okay, thank you all so much. And for more information about NEI products and our other podcasts, you can always go to our website, www.neiglobal.com. That's www.neiglobal.com. And I want to wish you the best of luck and success in your clinical work, working with your patients and their families. Thanks so much.
Thank you for your participation in this NEI CME podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to go online and print your certificate. This concludes the CME podcast presentation.